Hello, everyone. Welcome to Ask Concussion Doc. Today's episode is with special guest Jenni Diamond. We're talking about return to school. I'm just going to do a little bio on Jenni, and then we'll kind of dig into it. So, Jenni Diamond is an occupational therapist and certified personal trainer. She is the director of occupational therapy services at the Neurology Centre of Toronto. At the Neurology Centre, Jenni manages a team of therapists and provides treatment to patients who have sustained one or more concussions. Jenni is passionate about concussion prevention, education, and management. For more information, you can visit www.jennidiamondhealth.com and or http www.neurologycenteretoronto. You can check out Jenni's Instagram accounts at Jenni Diamond Health and at the.concussion.ots. Check it out. Is that what you're joining me on? Are you on at Concussion or at
I'm
Concussion
on the at Concussion OTs, yeah.
Nice, right on. So you can click on her profile if you're watching us live. We are doing this live. So Jenni, welcome again.
Thank you.
This is our second episode. We've done one previously on return to work. So if you haven't checked that out and you're interested in learning how to get back to the workplace, check that one out. Today we are talking about getting back to school. Anything else you want to add on your background or bio that people should know about you before we get going?
I think that's good. I work as the director of occupational therapy services at the Neurology Centre of Toronto, and the majority of my practice is working with individuals who've had a concussion and or have persistent concussion symptoms. And I work a little bit also with people with chronic headache issues. So that's a little about me, and yeah.
Is your practice mostly adults or kids or mixed?
It's both. I'd say we see definitely majority adults, but we see kids too, any age. And we have a team of 5 OTs, including myself now. So it's definitely been growing. Wow. I was the first one there and started up the program there. And since then, we've just been growing more and more and developing our program. And it's been fun.
Good. I guess that shows the need for the program, right?
Absolutely.
As the demand grows, you need more staff to do it. So good for you. That's awesome. Okay, let's dive into the topic. So we'll talk first. I think the way that I outlined this is we'll talk about acute and kind of how we go through that, what type of accommodations we might want to include, what the stepwise process is, when someone should try to go back or maybe when they should hold back, that type of stuff. And then we'll get into persistent symptoms, which I think is a difficult topic for many. If they've been off for a while, how do they get back into the swing of things, even like grade school, high school, but also into the university ages where there's obviously a lot more independence and the subject matter is a lot more difficult. And, it's there's a lot on the line with, costs and tuition and things like that. So I think that'll be the way that we frame it up. And then if anyone has questions that's watching live on Instagram, feel free to type them into the chat. And if we have time, we can kind of scroll through those and have those types of questions involved as well, which is one of the benefits about doing it live. Okay, cool. So let's dive in. So, now, in terms of return to school from an acute standpoint, do you typically wait until asymptomatic status, meaning that the symptoms have gone away, or kind of what's your way of doing that? Because I know there's some debate and controversy around that. But
there absolutely is, and it's a really great question. So our approach is, especially being an OT, occupational therapists are always focused on meaningful activities and can you do your daily activities? And so as an OT, our focus is a little bit more on activity tolerance rather than symptoms. So of course, if someone's feeling really sick and symptomatic, I mean, they're probably not going to be able to do much of their activities anyways. And so that sort of gets covered. And they'll of course know they need to rest and they'll have to rest. But what we usually do is focus on activity tolerance. So in terms of sending someone back to school, we're always going to follow a stepwise process where we make sure that they can tolerate a certain amount of activity first. And once they make it to that stage, they can move to the next. For anyone really listening who working with a healthcare provider who can come up with an individualized program for you is the best possible option. If you don't have access to that option or you're waiting for an appointment, there are return to school guidelines. Parachute Canada, for example, has these guidelines. So there's a bunch of them online. If you just Google concussion return to school guidelines, I don't know Dr. Marshall, what would be your go-to return to school resource? Use Parachute, or do you have?
We typically just use the standard stuff from Berlin, which is the 4-stage return, which I think is similar kind of across the board. They have, it's a very similar process through most guidelines.
They're all quite similar. They all encompass the same steps, which really is start with rest, then some basic activities at home, then some school related activities at home, and then getting into a graded return in school. And so you can find one of those strategies that breaks it down and it gives you a nice guideline. But of course, within that, there's a lot of individualization that has to occur. And so whether or not you send someone back with symptoms, it's really, if you're managing this on your own, it's a little trickier. If you have a healthcare provider, you can individualize this. But what I will say is, just because someone has symptoms doesn't mean I won't send them back. Now,
for the healthcare providers out there, how or what do you look at? So those that have a healthcare provider, that's fine, they can lean on them. But what about the healthcare providers that are, unsure as to what to do?
Absolutely. So what I like to do is I like to establish 2 parameters and then compare them. And it's similar for return to work. So if the goal is to get back to school, I'll preface this with, I'm never going to send someone back to full-time school after a concussion. It's just not likely to be as successful. I'm always going to send them back part-time first, even if it's part-time for a week, and then they want to go right up to full-time. Fine, I'm working with the individual, but I will never send them back to just a full week. And so always what you want to establish is, what is the first step to going back? So am I going to send them back for 1 class 2 days a week, or 2 classes 3 days a week? And whatever that realistic goal is that you come up with based on the student, based on their current activity tolerance, their symptoms, what grade they're in, or if they're in university, etc. Once you establish that goal, then you have to look at their current activity tolerance. So these are the 2 parameters. The first being, what is the goal of what do you want to bring them back to? And then what is their current tolerance for these activities right now from home? And then what you want to do is you want to compare the 2, and you want to make sure that their tolerance for these activities at home is equal to or greater than what the goal is that you're working towards achieving. And so I'll just give you an example of that. If they need to be able to tolerate 3 hours of in-person classes, well, can they from home at minimum do 3 or maybe even 3.5 or 4 hours of listening to YouTube lectures on certain topics and taking notes, or some of the school-like strategies that they would have to do.
And you do that even in the acute stage, even if they're they've been off school for a couple of days and they're starting to feel better. Would you even do that?
So define acute stage. Define, like, what timeline are you thinking here?
Let's say that they're 5 or 6 days out from their injury.
Okay, so 5 or 6 days out from their injury. I mean, it depends how they're feeling. Some people feel 100% fine 5 to 6 days out from their injury. Let's say someone, again, do they have symptoms or they have no symptoms? Let's say they have no symptoms. They're doing things at home. They're, maybe eating dinner with their family, having conversations. They're on the computer, no issues. Great. I would send them back probably for a half day just to be safe. And then if, again, everything's fine, cool, we can ramp it up. Versus if they're struggling with their symptoms, then again, we're managing, where are they at? So I think, whether or not you do this in the acute stage, it's not, to me, so relevant how far after their concussion they are. For me, it's more of what are their symptoms like, and more importantly, what is their activity tolerance like? Because you get people who are 1, 2, 3 years out from their injury and they have terrible activity tolerance, or I shouldn't say terrible, but more like severely limited activity tolerance. And then you have people who had their injury a week ago and they're a little bit more fortunate and they're totally fine and their symptoms go away. So I would say it's definitely more individualized and not so based on the acute versus long-term stage. I don't know. I'm curious what your take is on that and how you would approach that.
Well, I mean, I don't take too much. I guess I don't get too concerned about it. I try it and see how they do. Like, I tend to do like a trial and error type approach more so. So I kind of follow, like what's in Berlin is, if you can tolerate 45 minutes of at-home activity without increasing your symptoms. So I usually use that as my way of dictating. So if you have symptoms, that's not as concerning. It's more concerning if when you do cognitive based activity, those symptoms increase to a significant degree. I kind of use it like the treadmill test scenario,
Yes.
where if you have a increase of 3 or more symptoms, from your starting point, then I would consider that to be a significant increase. If you don't have a significant increase, then, and you can tolerate 45 minutes of doing homework at home, then the next step, I say, try a half day. Right now, if you're able to make it through a half day, great. Then we can keep going with that and try to push you to a full day. Especially early on in the recovery, I find that, I just kind of rip the Band-Aid off and see what happens. And if they go and they're like, oh no, half day was too much, then we can look at, okay, where are some accommodations, and, do we reduce the time here? That type of thing. So I take more of a trial and error type approach, I guess you could say.
Yeah, interesting. And there's no real wrong answer. I mean, at the end of the day, you're not hurting your brain unless you get an actual re-injury. It's just not going to be helpful to your recovery if you're experiencing all these symptoms. And of course, it's not good for your quality of life. I think, perhaps maybe my bias as a healthcare provider is working with patients who do struggle through these returns, and because those are the patients who typically then need help and need therapy support. And so I think that's probably why I tend to go with a more conservative approach and take things slowly, because I usually say, your body will know, and you will know if this feels easy and you're good to go. So we can always ramp it up faster, but I usually do try and start with a more conservative approach and prepare them a little bit at home first.
It's just interesting, like two differing approaches on it, because I'm more of like a, let's throw you in and see where you sink or swim type of thing, and if you have trouble, then we can figure something out. But I mean, you never know, I could be doing some sort of harm with that, in terms of just that sense of failure, I guess, where if they do go back and they do have that, I wasn't able to do it, and maybe that creates more problems just because of that kind of letdown. But I don't know, like most of the patients I found have been able to tolerate the half days and the progression if you're there in the acute stages. Like that, it's when the PCS stage hits that's tough. Do you typically give accommodations, like for a patient, like let's say you want them to go to 3 hours of class, but you give them breaks in between, or what type of accommodations do you typically provide? I guess it's always patient dependent, but are there ones that you seem to provide more so than others?
Absolutely. Yeah. So accommodations are key. If you're someone who's listening to this, who's recovering from a concussion, or if you're a healthcare provider working with your patients to help them get back to school, you're definitely going to want to look at a list of accommodations, and, or if you're the patient, speak to your healthcare provider about those options. It's super individualized, but the ones that I tend to use pretty much across the board for most are extensions on any assignments as appropriate. Same thing with removing any testing for the time being until we know that they can manage school on its own without testing. Often, depending on their level of schooling, often I'll ask for like a note taker, so that during class they don't have to listen and take notes. They can just focus on listening, being there, taking in the auditory and visual stimuli, and not adding another layer to that. So getting them notes either from a note taker or from the teacher. So those ones, and then depending on the individual, again, I'd say like majority of my patients I work with are in the more persistent concussion symptom category. So they do often need more supports, more accommodations. So something that I often would recommend, especially if they are struggling a little bit more, is breaks between classes. So sometimes that means leaving class just even like 10 minutes early to get some quiet time between classes before the hallways get really busy, or to go and take, a good quiet rest break. And then I think those are the main ones. It's interesting because virtual schooling has changed this a little bit. So there's a whole bunch of other accommodations I recommend for virtual school, like such as keeping your own video off, so you don't feel like you have to stare at the screen and you can just listen rather than look in terms of screen time, or like asking your getting printouts of the slides for the lectures ahead of time instead of seeing them live on the computer screen. So those are some of the more common virtual ones I recommend. And I think there's probably a few I'm missing, but those are the ones that stand out to me off the top of my head as some of the key ones that I always recommend.
Do you think too many, like I know some people that there's so many different accommodations they provide. You got kids wearing sunglasses and hats and everything. Do you think that too many accommodations can be like almost a harmful thing?
I mean, to an extent, of course. I think it really depends how much the kid needs them and how much the accommodations help them do their daily activities and improve their quality of life. Because, there's always this debate over, let's talk about, for example, using sunglasses and earplugs. And like often I get this patient, especially when I was working more in person, this patient who comes in with, sunglasses on, hat over their head, earplugs in, they're like blocking everything out. And our goal long term is to work on getting rid of all of that. And so, that is the long term goal. However, when you think of someone in school or even in a workplace or out in the community, if wearing sunglasses helps them stay in school for a full day instead of a half day, well, that's huge for their quality of life.
Mm-hmm.
So I think it's to an extent, and I would say, yes, like there is an element of too many accommodations playing into, I mean, we can even take it a step further and playing into, the psyche of identifying as someone who is so needing accommodations and is so injured, and then, identifying with that persona. And that can be dangerous in itself for the individual, rather than trying to identify with, I'm healing, I'm improving, I'm getting better, I'm strong, I'm healthy, I'm going in the right direction.
Mm-hmm.
So there's definitely a big psychological element to that. But I would say when I break it down, I do tend to err on the side of as many accommodations as needed that would help someone perform better in their daily life.
Mm-hmm. Mm-hmm. I typically go with the, again, my trial and error approach. I typically go with okay, you can tolerate 45 minutes of home activity. Let's try a half day of school. And my typical accommodations are no tests, no homework, no gym, no recess. And that's kind of my baseline. And maybe I'll throw in a note taker depending on their age, right? Like if they're in grade 4, they're not taking notes anyway. So I just go, I just don't want them engaging in physical activity or playing, kickball at recess and getting a ball in the head. So I try to just, limit their chance of getting another hit, but no tests, no homework. So they're just going there to just be there and in that environment. I think of it more of like auditory and visual stimulation, as you said, and, peer interaction and seeing how they feel. And if they feel okay with that, then I'll try to push the time on that. But if they have issues, right, where, well, the lights are too bright, and then now I'll say, okay, what if we were to, add some accommodations in,
Love that.
kind of as you go.
Yeah.
I'm hesitant to like add too many accommodations up front, because then, like you said, patients can identify with that. And that almost creates almost like a sickness behavior sometimes, where we're afraid to, to get out there and do things.
It's like this learned helplessness, right? Where you identify as not being able to do things that you previously could do. So I 100% agree with you. I think, giving the least amount of possible accommodations needed. Now, depending on the person and their stage of recovery, that list still might be big. But going on the side of, okay, let's do less and then adjust as needed is huge. And I do want to emphasize also the no recess, no gym, because that's really important too. And I didn't mention that initially, but thank you for bringing that one up, because that's just a safety thing. Like we just want to avoid any second impact syndrome and risk of a re-injury.
Yeah. Are there any subjects that you've heard your patients describe as being more difficult to tolerate than others?
So, what's funny, it changes a lot. It's very individual. So usually when I'm recommending which classes to go back to school with, I usually have people go back to the class that they either find the easiest or that they enjoy the most. Because also if they're happier, they're going to feel better. If they find something easy, for some people that's math. For some people, math would be the last thing they want to do, right? So it really depends. And then also you sort of have to balance it with, which classes are the most important. So, if someone needs certain prerequisite courses to continue on to the next grade, and English is one of them, but art class is not, well, even if they like art the most, it's probably more important for them to complete English and not do art. So it's a little bit of balancing, I'd say, those two things, like what are the key classes that are the most important for them to go back to, and then also what comes easiest to them, what will be the most successful, the most positive experience for them. And once we've nailed that, let's add in the next piece.
Right. I think that's a great tip. Like I've never even thought of it like that. I try to balance a schedule, particularly if it's a high school person. Let's say they have, a couple periods before lunch and a couple periods after. If I'm going to send you back to a half day, generally I'll say, well, you have a spare in the afternoon, like that doesn't really count. But if they also have, like music class, I'm like, I don't want them sitting there like, blowing hard on some sort of wind instrument or something. Let's, or even the noise aspect of that. Let's try to find a different class for you. Or if they have gym on one of those periods, that doesn't really make sense either. Right. So that's as far as I accommodate, but I like the idea of saying, what class is your favorite? And let's start there, because then if they're interested in the subject matter, they might even just lose themselves in that and be like, actually, I was fine with that. Okay, great. Now they've proven to themselves that they can do it.
Right.
And then away we go. I think that's a great tip. I'm going to steal that for sure.
Yeah, I hope you do. And it's interesting. I've definitely had some patients come back and say, oh yeah, like, French is easy, but geography, I get the worst headache. And so it's like, well, same amount of time, like you're in class, it's the same environment, but it's a different subject, and it's super relevant, right? It's a different level of cognitive focus depending on how challenging something is for you.
Now, I just thought of this idea, but do you think that is somehow related to, humans tend to enjoy things we're good at. That's just the nature of things. We really shy away from things we're bad at. We tend to gravitate towards things we're good at or things that come naturally to us. Do you think that maybe one of the reasons that those classes are A, enjoyable, and B, easier for some people is that they've developed the neural connections for that particular subject matter? And then after a concussion, they have more reserve capacity for those subjects?
That is so interesting.
Huh?
Yeah, that's really interesting. I mean, look, I don't see why not. It's definitely possible. And, when you think about how our brain responds in a concussion and that brain energy reserve, and how, our brain is reserving energy for our most basic functions, keeping us alive, for supplying all our organs and keeping that all going. And the extra energy that remains, I mean, it's probably for a lot of these functions that maybe aren't as ingrained within us. And so, yeah, I'm sure there's something to be said about that.
I think that's a good research study. If anyone's listening that wants to take that one on, I think that would be an interesting one. You could probably do it with like an fMRI or something. If you get them doing subject matters that they enjoy, you could see the level. I don't know. It's interesting, but we've seen this before. I've seen it in, let's say reaction time studies where they show that the non-dominant hand is, still showing deficits when the dominant hand is returned. Right. Now that could be something to do with, just reserve capacity around that area. You have more neural connections for the dominant hand, and therefore, even if you have dysfunction, you still have enough connections built that it's almost imperceivable. But on the non-dominant hand, maybe now it starts to show. And I just thought that right now, but anyway.
Yeah. And I think you could even take that a step further to any injury or illness, right? It's like if you have a higher capacity for something or higher neural connection, stronger neural connections for a certain activity, even if you're sick, regardless of what it is, you're still going to perform better during your illness compared to someone who doesn't have the same strong neural connections for that specific activity.
Mm-hmm. Yeah, I mean, it definitely makes sense. And here's another one for you. Do you allow for return to sport prior to return to school? I mean, like in a concurrent setting. I don't mean full return, but I mean in a concurrent setting. How do you address that when you have somebody that
This is a great question, especially because there is so much confounding information on this. Like if you look at even the return to sport and the return to school guidelines, I mean, some of them say, don't even start your return to sport guidelines until you're back at school full time. And really the overarching idea is, return to learn first, return to school first, then return to sport. However, we know it is so important to start on a low to moderate intensity exercise program as soon as you can after 1 to 2 days of recovery. So, and we know that that's been shown to improve outcomes after concussion and speed up recovery times in the research. So I think there needs to be some changes actually to the guidelines around that, because I do think it's not clear right now and it's actually quite confusing. So my approach though is, and I guess the real differentiating factor should be that, physical activity is different than sports. So the idea being, playing on a sports team, two things. One is, of course, if there's a risk of re-injury, and that's something you always want to get medical clearance by your physician or your primary care provider for, before you go back to any activities with a risk of contact and re-injury. But then there's also the concept that, if you think about playing, so actually let's take it from this angle. If you think about school and all the cognitive demands of school involved, maybe you're sitting at a desk and you're focusing and you're processing and you're making these reflections and insights. So that's what you do in a school setting. And then in a sports setting, you're doing the same thing on the field. If you're playing soccer, you're using your spatial system, you're using your vestibular system, you're looking around you, you're processing, you're thinking, planning your next move, all of that in combination with physical activity and physical challenges. And so in theory, playing sports is a lot more challenging in some ways than just cognitive function on its own, in terms of all the different systems that are being recruited to support you and help you, and in terms of then how your symptoms might respond. So that's sort of one perspective that I take on it in terms of why you should go back to school first before sport. I mean, there's also the idea that priorities and balancing your energy. And we want to make sure kids are in school and they're doing that before they're going back to their sports teams. And if they only have the energy for one or the other, well, let's make sure they're not behind in their learning. So I guess to summarize all of that, what I would say is, starting from the very beginning with a low to moderate exercise program, ideally created by your healthcare provider, nothing with a risk of falling or re-injury, and slowly grading it up as per your symptom tolerance, and then not going back to team sports until you're tolerating full-time school. Mm-hmm. I will add, one sort of caveat to that, in that, again, it's quality of life. We want these kids to feel good and be happy. And if someone's favorite thing in the world is playing on their sports team, and they can do that in a setting where there's no contact, and they're here, with this concussion, their life is stressful, it's really challenging now, they have to plan out all these things for getting back to school and planning out their rest breaks, and it's just this big headache if they can't socialize. And the one thing that makes them really, really happy is playing on their sports team, and they can do it safely. Well, that's really valuable. And, that, there's so much to be said about, keeping people happy and improving their quality of life to ultimately help get them better and improve their self-efficacy and perceived capability and success.
Mm-hmm. We used to take, the way we used to do it is we used to do return to learn, then return to sport, because the original kind of literature on this, not even original, but just, post Berlin, that's kind of what the consensus was, is do not start return to sport until you've returned to school. But then over the years, the amount of data coming out on early exercise and its benefits in recovery, we actually now run them concurrently, but we don't allow for a full return to sport unless we have a full return to school. So kind of the way we juggle it is, within the first 5 days, we're putting you on a treadmill, whether you like it or not. And that's the first step. You're doing your return to learn stuff. You may be still at home doing stuff. But if you're still symptomatic, at day 4 to 5, we're putting you on the treadmill to try and get that kickstarted. And you may be in half days of school already, you may be in full days of school already, we don't know, but we're kind of managing them almost as independent events. And then if you're able to pass the treadmill test, well, the next stage is you're allowed to return to a non-contact activity. So if you're able to go and practice with your soccer team, and you can just do, individual dribbling drills with the ball, you can take some shots on net, you can jog around the field, you can interact and socialize with your teammates. You're part of the team still, which I think, like you said, it's kind of a psychological boost as well if people enjoy it. And you're still not putting yourself at risk, but you're still getting physical activity, which is beneficial for recovery. And then all of a sudden it's okay, I'm ready. I'm having no symptoms at practice, but I'm still having trouble with, school. You say, okay, but that's still something. So we can't clear you to fully return because you're still having some sort of issues, right? The only way you go back to sport is if you are issue free in terms of full return. So that's kind of the cutoff point. It's like, we'll let you do non-contact practice forever, but until you're able to fully establish yourself in school with no issues. And then we will run you through full physical exertion testing, baseline retesting if we have the info and all that to make the final sport decision. But we don't even do that until you're back in full school. So that's kind of how we've juggled it. But it's interesting, even over the past couple of years, we've completely changed our
It's
approach.
changed a lot the last couple of years. Yeah. And it's interesting how, things really are changing quickly year to year. And I think, it's such a good perspective the way you outline that, because we want kids doing the physical activity anyway. So why not have them do it in the sport they enjoy, in a social setting? I mean, again, if they can tolerate it, if it feels good. But I think that's actually, the absolute way to do it is if they can tolerate it.
All right, let's switch gears now to PCS. So PCS, for those who don't know, is persistent concussion symptoms. It used to be called post-concussion syndrome. These are the people that have symptoms for months and months or years and years. And, how do we, obviously with school, kids are generally, just a couple months out or even a couple weeks out and still not able to get back. How do you change your approach on this? How do you kind of change how you look at this? Do you include, cognitive assessments in this? Do you still take it by a symptom-based approach? Like, how does that change for you typically?
Yeah, it's a great question. So I think the bigger thing is just, in most cases, moving a little bit more slowly with it. Chances are, if they have persistent concussion symptoms, they probably tried going back to school. It probably wasn't successful. So that you have to be pretty careful and individualized in your approach. Whether or not I do a cognitive assessment, it just depends on their abilities. So if they're complaining of no cognitive symptoms, but they're just getting, really bad headaches when they are doing any thinking tasks or looking at a computer screen, then I'm probably not going to focus on doing a cognitive assessment. I'd rather put our time towards building up a symptom threshold and tolerance for their activities. So I don't know how much it really differs compared to acute in terms of my approach. I would say it's fairly similar. It's just more in terms of the types of profiles I see, these types of patients, they tend to need a little more support and a little more accommodation.
I just thought of something else when you were saying that. How much, like I find this too, is when people are going back to school and, they'll start to get a headache later in the day. And a lot of people will attribute that to cognitive loading. And I kind of take a different approach. I say, well, it could be a variety of things, right? It could be ocular motor. It could be neck and postural, right? Like if you have neck dysfunction from your injury and now you're sitting in class, with that for an extended period of time. Like I just thought of it now because I'm sitting here kind of in a slouch position.
I just sat up a little straighter.
My mid back starts to hurt. I'm starting to get, pressure on my neck, and you get that anterior head carriage and stuff. And a lot of these people might have other dysfunctions, not necessarily, cognitively based.
That's a great point. I think actually that's where, as any healthcare provider, I think that's important. But I think as OTs, we do have a unique lens in that we do have a little bit of expertise in all of these domains. We have, of course, the areas that we focus on a little bit more, which tends to be return to activities, energy and fatigue management, cognitive strategies, and sleep. But we do have expertise in all of these domains. And so my role, at least, and when I work with my patients, I'm looking at all those factors. And so I'm saying, okay, you're having headaches from screen time. Well, what's the underlying issue and what things do we need to fix? So is it the screen or is it the ergonomics that needs to be improved? And so we're going through, all of these things. Have you been assessed by a chiropractor or physio? Have they checked out your neck? Have they checked out your shoulders? Do we know if it's coming from tension, or is it purely, have you seen your optometrist? Like, when was the last time you've had your prescription checked? Sometimes patients just haven't gone back in 3 or 4 years and they need their prescription updated. So really looking at all the different factors that could be playing a role into this symptom, like you said.
So, on that now, if I'm a parent, what advice would you have for a parent that has a child in, let's say, grade school to high school that's, struggling to get back? What type of resources would you have them look into? What type of types of practitioners would you recommend they maybe get in touch with,
Mhm.
or things that they try to do to kind of pace themselves back in if they
Mhm.
didn't have access to care at all?
So not practitioners then, you mean? So more just like resources or?
Both.
Okay.
So I mean,
Yeah,
like what type of thing would you look for with a practitioner? What type of things could you be doing on your own if you didn't have access to
absolutely.
that? What type of resources might be available to you?
Absolutely. So, I mean, of course, my bias is I am an occupational therapist and I understand the profession of OT quite well. And I feel that it plays a really important role in concussion rehabilitation and particularly in return to activities, because that really is what OTs hone in on with their patients. So what I would say is if someone's struggling with return to school, that is an immediate referral to an occupational therapist if you have the resources. Um, OTs, and we mentioned this in our last podcast, we don't specialize. So you don't have to see necessarily an OT who specializes in concussion, because all OTs are going to have the same training and resources to help you be successful. However, I would say, working with an occupational therapist who does have their practice in concussion, they very likely will have had more experience, more training, have taken more specific courses and workshops in that area. So it's probably a good idea to see someone who works at a clinic that is focused on concussion, or their own practice is focused in concussion. So that's one thing in terms of healthcare providers. I definitely would also recommend seeing a chiropractor or a physio, just to rule out any of the physical issues that could be happening that are leading to symptoms, because so many of my patients, it's in their neck. And once they work through those neck issues with their physio or their chiro, so many of their symptoms are improved. And so, it's just a nice thing to get assessed and check off. And if your neck is fine and your body is fine, and the physio says, you seem pretty good, then that's great. And that's good to know as well. It's just good information. So for me, my typical referrals are OT, so occupational therapy, physio or chiro for the physical aspects, and then psychotherapy. And that, again, it's a bit of balancing resources, both financially and in terms of time and energy. But the psychotherapy piece for a lot of kids is huge because it is so challenging for them. Those are typically my three referrals, and then possibly to a speech language pathologist as well if they're having persistent language or communication issues. And then possibly to optometry as well. So those are my main referrals. And then in terms of resources, actually, Holland Bloorview Kids Rehab Hospital has a really great resource called School First. And it's like this whole handbook that breaks down so much detail of how to go back to school. So if you're someone who does want to do a bit of research into this for your kids, if you're a parent listening, check out that resource, because it really breaks down everything from both like strategies and accommodations that can be used to like even how to communicate with schools and who should be involved, and asking if a school has a concussion policy and who runs it and all the language you have to use. So that's a really great resource. And then I would say two other handbooks I really love are the Sunnybrook handbook on concussion, as well as also, again, the Holland Bloorview handbook. And both of those provide some strategies for just basic symptom management and helping you get back to activities.
Yeah, I think that's all great. I think you nailed that question. Now, getting into university students now, and I come across a lot of these that may be off school or have put their degree on hold for the time being, and now they want to go back. And usually it's in the context of, okay, I've decided I'm going back in September, and it's now June, and I'm shitting my pants, and I don't know if I'm going to be able to do it.
Yeah.
What can they do to prepare themselves for that?
Absolutely. So, and that's actually the time of year that I tend to say, like even some of my patients who, maybe they're in grade 12 and they're doing a lot better, things are good, but then, we know that next year they're going off to university. And so I usually say, why don't we meet up in June or July, and we can at least put you through some practice activities to make sure you can tolerate what's about to come up. So I do think, having a couple months to prepare before starting a new year of school is great. If you don't have a couple months, I mean, you do what you can, you use the time you have. But in terms of what you can do, really it's simulating that school environment from home before you're actually in it. So can you get a textbook that you're going to have for even one of your actual courses? Can you locate that in advance and start, practicing reading through it and taking breaks? Set a timer for 20 minutes. See how you feel after doing that a few times with some breaks in between. And if it feels good and your symptoms aren't getting worse, great, let's try the same thing, but with 30 minutes. So building up those kinds of activities. Similarly, the same thing for screen time. So, even just doing writing, like doing some journaling on a computer as if you would be writing an essay, but you can, write what you did that day or choose a topic that's interesting to you. So doing these simulated things depend and ideally having them align as close to the actual subjects you'll be taking as possible. So I've had kids look up, videos on YouTube about certain topics that they'll be learning, and I have them, sit there, listen to it as if it's their own lecture and take notes, and then, see how effectively they were able to do that.
I think with this day and age with YouTube and stuff, I think it's so, and even if it's, while screens still bother me, turn your screen off, just listen and take notes, because that's the pace that things are going to be going at. You can get, university lectures in a variety of different ways on YouTube. People have published their whole thing. I mean, you can find Jordan Peterson lectures on YouTube too. You just, close your screen and just write notes on a bunch of different topics. And, in the field that you're interested in, you can always find something. And I think that's a demand. I like the idea of reading a textbook too, because studying, that's going to be a big thing. So, how do you do with all-nighters, I'm just kidding.
Yeah, that's something I would definitely avoid, especially during concussion recovery. I was never the all-nighter person. I was the may my 8 hours of sleep bless me for tomorrow's exam and save me and let me get through it rather than cramming the night before. But
yeah, I was a mixture of both, but you could frequently find me in the Weldon stacks at Western.
Nice.
Well beyond the darkness hours. So,
oh yes.
Anything that you think we've missed or anything you want to add before we kind of flip it over to see if there's any questions here on the live?
Let me think. Let me just see if I had a couple notes, and I just want to make sure that I covered them. I don't think so. Nothing specifically that I feel like is super important. I mean, there's a whole other side of things in terms of cognitive rehab and cognitive strategies, which really plays in. And I think, that could be a whole other podcast episode in terms of those kinds of strategies. There's just, so many to name, but I think just at least for today, recognizing that there are many individuals who are going to have a hard time with the cognitive aspects of return to school, and maybe they can tolerate the work and they're not getting headaches necessarily, but they're having issues with their memory. They're having issues with their planning and their organization, or missing deadlines and then having to cram the night before. So there's a big role for OT, or similarly, but different, would be speech language pathology to work with kids to help them with those kinds of strategies as well.
So there's one question here about tinnitus. I don't know if it's really on point, so I'll skip it and see if there's other. We have one of our nurse practitioners from the States. She wrote, I think we were talking about difficult subjects. She wrote math and languages. So that seems to be her experience. She works at Children's Hospital of Philadelphia. And so deals a lot, obviously, with pediatric concussion. Playing music, how long would you withhold this before clearing them to return?
That's a really good question. So it's not so much about, clearance to return. It's more just about limiting unnecessary stimuli that might provoke worsening of symptoms. So what I would say is if you're doing all your other subjects and you can tolerate all the rest of school, well, the next step is probably to add in music and see how that goes. And maybe with accommodations, maybe, starting for just half of the class instead of the full class, or using earplugs to just decrease the sound a little bit. So it might be with accommodations, but it's probably one of the last things to add in, especially if you're someone who is having issues with noise sensitivity.
The way that I've done this in the past is I try to isolate, where the issue might be. So rather than going in and playing and being with all the other noise. It's like, okay, well, try playing at home for a bit and build up your tolerance to being able to play, right? Can you play for 5 minutes? Can you play
Love
for
that.
10 minutes? Can you play for 15 minutes? Okay. Can you play for the entire duration of what you would need to? Let's say it's 45 minutes in a class. Can you do that at home comfortably? Okay. Now, can you go and just sit in that class for 5 minutes, for 10 minutes, and just dealing with the noise on its own,
Perfectly
and
said.
now marry them together and see how you do. That's
So you use the same level of detail and preparation for music class as I do for the rest of school.
yeah.
You don't use so much the guess and check method. You're like, let's be really careful and strategic with this music because it's gonna be
Well,
pretty bothersome.
there's just so many variables, I think, with
Yeah.
music, because especially when it's, I'm thinking wind instruments and like, increasing your intrathoracic pressure as you're breathing through like a trumpet, that's going to be an issue. But also then you have the elevated noise, and the crowd. And I just think there's a lot of moving parts.
Mhm.
But
we
yeah.
had a really good comment in the chat that I just caught sight of, and you can even break that up in terms of, if you're playing a wind instrument, not necessarily blowing into it, but just practicing the keys with your fingers and starting with that and
Right.
building from there.
Right, exactly. So I think the whole thing, and this is like what I always try to get across to patients, is like, figure out what you need to do and then really just chunk it up, right? And I think this is kind of a concept of like cognitive behavioral therapy, and that too is like, when you look at a big thing that's over here, like it seems almost overwhelming, like, oh my God, I can't play in the band because there's so much going on. But what you do is you go, okay, I want to be able to play in the band, let's say in like 6 months. So then you kind of bring it back. Okay, what do I need to be able to do first? Well, I need to be able to play by myself. And well, breathing through my instrument is tough, but I can start working on the notes, and I can start, doing breathing exercises without the instrument, and like just really chunk it up into steps and gradually just add those together over time. And before you know it, within 6 months, you can be playing, in the band. And I think that's where, there's a quote that people underestimate, what they can do in 10 years or something, and overestimate what they can do in a year. I think that if you think about it far enough in the future, bring it back to, where you are now in small pieces, and then, build. I think that's really the key.
That is really the key to all of concussion rehab,
all
to
of
be
it.
honest. Yeah.
All of it. Let's see if there's any more. So helpful. Thank you to both of you. Yep. There's the wind instrument once. Tinnitus, more info. If people really want to talk about tinnitus.
Do you have an episode on tinnitus that you can refer them to?
I think I do, actually. Yeah. If you want to go to previous episodes, go to YouTube and look up Ask Concussion Doc, tinnitus or tinnitus, however you want to say it. And I have some information on there. It's very, the problem with tinnitus is we don't really know a lot about it. I think that's really the big issue, is we don't totally understand the pathophysiology of it. We don't totally understand, treatments. There's some treatments with audiology where they'll use, frequency stimulation to try and mimic the sound and almost kind of desensitize your brain to that sound level. So there's some evidence on that. There's some actually evidence that tendinopathy of the SCM muscle can actually cause tinnitus, and actually treating the SCM, treating the upper part of the neck, can actually relieve tinnitus in some patients. And so that's something I always try. There's some evidence to suggest that it could be inflammatory. And so, increasing or decreasing pro-inflammatory foods and trying to really clean up your diet may have a reduction in neuroinflammation, which then can potentially alleviate that. So that's kind of the gist of it. But I think that you kind of go through the method and you just try to kitchen sink it, because we don't necessarily know what's causing yours versus anyone else's. And so I think the best advice is to say, eat a clean diet, get somebody to look at your neck, talk to an audiologist, right? Like you can't go wrong with that strategy.
And
So
probably see an ENT also, right?
Right. ENT typically will look for any pathology that's there that might be an issue. And then what they'll usually do, if there is no pathology, is send you to an audiologist anyway. So, but I mean, I think it's important to rule things out. So I think that's a good point you make. As an OT, do you travel a lot to different schools to assist children? If so, do you experience challenges attending to the needs of your patients as you progress them through their rehabilitation?
Okay. I'm just trying to understand how those two parts correlate. Let me just scroll back a little bit.
Do you travel to
so
school?
I'll start with that. I don't travel to schools. I see patients virtually. So I usually see them after school, before school, or during school, depending on their schedule, or during typical school hours during their schedule. So no, I don't. And then the second part of that was, what was the if so? Because I could hypothesize an answer.
Yeah, I'm not sure. It seems like they're relating it to traveling to different schools.
How do you stay on top of your patient's needs? Like, is this coming from maybe another healthcare provider or OT who has trouble, it's like a lot of travel time, or I'm not totally sure.
Mm-hmm.
Just
Quinn, can you elaborate on that maybe?
It's also not letting me scroll up here. So, oh, there we go. Okay. So if so, do you experience challenges attending to the needs of your patients as you progress them through their rehab? I'm not sure how that relates. Yeah, I think if you can give me a little more information on that one, that would be good.
They just replied again and said, I know a few OTs that have to travel for their work in rural areas.
Okay, so yeah, it can be challenging following up with their patients because of the wide area they have to cover. Oh, okay, yeah, no, I can imagine that would be quite challenging if you're losing time to travel time, right? So, but that's it's definitely needed having services there, especially if people don't have access to online care.
Yeah, I would think in the age of Zoom though, you can probably have a lot of width to your domain.
Yeah, a lot of my exactly. I see. So at our clinic, we see people virtually all across Ontario. So I see people in rural areas, and some of them actually have to do their appointments from their doctor's office, and they go there and use their Wi-Fi and do that. So that's an option too.
Okay. I think that's it. Everybody, thank you for joining us today on the live, and thank you for listening. Jenni Diamond, everybody, you can find her at jennidiamondhealth.com. You can follow her on Instagram at Jenni Diamond Health. You can also follow at the concussion.ots. You can also check out the Neurology Centre Toronto, which has neurologists, OTs. I think you have PTs as well.
Yep, psychotherapy.
You got the full team. Really great center. So check that out if you're in the GTA and in need of some concussion help. Right on, Jenni. Thanks for joining me.
Cool. Thank you.